All right. So as I said, those always happen on Friday nights. So that was 2 weeks ago. 47-year-old female. She had no past medical history, no allergies, 3 kids. She was on birth control pill, and she presents to ER in a primary care hospital with acute onset shortness of breath of less than 1 hour ago. That's around 2 o'clock in the afternoon. On exam, she's sinus at 130. There's probably consensus on the panel that 130 sinus is bad with low blood pressure. And she has cold and clammy skin. She's diaphoretic. She's got dilated IJs, and a bedside ultrasound shows a small hyperdynamic LV and severely dilated akinetic RV. The ECG shown here illustrates the sinus stack with some signs suggesting of RV potential strain with S1, Q3, and T3 typical findings. This is actually not her ECG, but hers was almost the same, so I picked the one that we saw something instead of the one from her that was of poor quality. Lactates were 5.4, and the working diagnosis from the emerge doc was that it was probably a submassive PE with significant hemodynamic instability. And she had no contraindications to lytics, and she started some norepinephrine. But the patient deteriorated, and the norepinephrine was cranked up to 0.5 mics per kilo per minute, which is considered moderate to high dose. Given the diagnosis of massive PE now with a patient with shock, they gave her TPA, but the patient's level of consciousness deteriorated, so they had to intubate her. And at that point, they called us, and we suggested adding milrinone to the patient, which was started at a moderate significant dose. And after 3 hours from her presentation, she had lactates of 9.5, and they organized transfer after the lytics were given and the patient's airway was secured.
And of course, it's 5 p.m. on Friday.
Yeah, that's the usual. So she gets to our place. It was around 5 p.m., but the 8:15 is real. She arrived with her milrinone and norepi at moderate to high dose. And we had TE showing severe RV dysfunction, a PFO with right to left shunt, and there was a clot visible in the right PA. But the IVC collapsed on expiration. This was her X-ray. You can see that there's consolidation on the left lower lung, left upper lung, and it might be some pulmonary infarct from the PE. We put a right IJ showing a CVP of 6, left femoral heart line, confirming the low blood pressure despite the vasopressor, and the blood gas showed a lactate of 5, a CO2 of 32, and a PaO2 of 69. We were quite surprised with the CVP of 6 in this patient that was still peeing, and this is the TE we found. So here you have a 4-chamber here showing left ventricle on your right side, right ventricle here. This is enlarged, and it's moderately dysfunctional despite inotropes, but mostly it's enlarged. On here you can see in diastole that the left ventricle has a D shape, which shows that there's overload on the right side. And finally, on that, this is the aorta in short axis, and that's the main pulmonary artery and right pulmonary artery, and this is a clot in the main right pulmonary artery. So it's a pretty big clot that's there despite having received lytics a few hours ago. And now we're stuck with that young lady patient with high dose vasopressors. And what's the next step? So question we had was, should we give a fluid challenge? So who would give a fluid challenge to that patient with the CVP of 6 and a collapsing IVC? All right, great. Who would do a CT scan for this patient that's unstable, intubated on many pressors and inotropes? Okay, couple CT scans. Who would re-give some lytics to that patient that's still unstable despite having received a first full dose of TPA? That's less than 6 hours after the first dose. Of course, she's already on heparin. Okay, so re-thrombolysis. Who would send that patient for embolectomy, surgical embolectomy? 1, 2, sure, couple. Less than 6 hours after lytics, thanks. Who would go for peripheral VA ECMO? 1, 2. All right. So,
What about
Percutaneous.
percutaneous thrombectomy? The angiojet.
so angiojet, we'll come back to the option. So there's percutaneous clot lysis is something that could be done. Most catheter options are clot fragmentation rather than clot embolectomy. So for us, it was quite important to try to understand what kind of embolic load we had in that patient. So we went and we added the nitric. So the patient was quite awake, which was, from our standpoint, probably contributing to her increased oxygen demand. So we rocked her and sedated her. We obtained a CT scan. We cranked the PEEP because she had quite a bit of hypoxia. And we did a leg ultrasound at the bedside to make sure that we didn't have tons of clot waiting there to re-embolize and put her into cardiac arrest. We took the lactate going from 9 to 5 as a good sign of early resuscitation, and maybe we were naive, but seeing a CVP of 6 and a lactate going down with a patient that was urinating profusely without diuretic, we thought we might have turned the corner and the patient might just do better. So this is the CT scan. You can see that the left upper lobe is densely consolidated. You see the pulmonary artery appear here. It's fully filled with clots. And the clot burden is massive. There's clots everywhere, not just in the proximal pulmonary arteries. So the team at that point, we were worried that if we just did clot fragmentation with a pigtail or angiojet, that we might just disperse the emboli load distally without decreasing significantly the pulmonary vascular resistance. So we decided not to go for that. There were still signs of RV failure. As you saw, the right ventricle is quite big. It's taking most of the apex. You also see that despite having the dye injected by the arm, it goes down in the liver, which is a sign that the right ventricle is not pumping that contrast very well. At 11:30, a patient became more hypoxic. The norepi dose, when we gave more sedation to the patient, was significantly increased, but the lactates went down to 2, and she was still peeing well. So now we were more in trouble, or because if everything went in the same direction, we would be happy, but now it's not.
I think what's interesting on the CT scan as well is that a lot of the clot burden is clearly towards the right lung, and she has permeable pulmonary arteries to the other lung, which is where all the consolidation is. So it looks like she probably aspirated at that point. So the only lung that actually has perfusion has consolidation. Yeah. So that's kind of her double whammy that I think from a respiratory standpoint is very concerning and explains a large part of the hypoxia.
It's possible that the radiologist at that point, they told us that the bronchi were opened, so that we didn't think we needed to go for a bronchoscopy, but they said that there was some dense distal clots, and that their hypothesis was that it was lung infarct from the embolic load, but it might have been the reverse and more of an airway problem. I'm not sure. Okay, so options. So who would decrease PEEP and ventilation pressures? None. Who would turn the patient on the right side? Okay, not many. Who would initiate VA ECMO on that patient with the lactates that are now 2, 1 ECMO, 2 ECMOs,
I think.
So from a,
maybe 3?
so the last blood gas was,
Well, she
PO2?
was still, her PaO2 was not very good. It was like 59 with 100%. CO2 was cleared adequately, and the pH was holding on with the lactates of 2 bicarbs higher than 20. Who would go for a stat embolectomy? 1. Okay. So probably that was some of those were right choices. So what we did is we did decrease the PEEP and the vent pressure because we knew that some of the hypoxia was secondary to the pulmonary. Nice. Some of the hypoxia was secondary to shunting in the patent foramen ovale, and we had increased PEEP earlier, and we thought we were just shunting more at the atrial level with a little more fluid. We were probably shunting more through the PFO, leading to a direct shunt and hypoxia. So we decreased the vent pressures, that helped. We also turned the patient on the right side, thinking that probably there was some real shunt happening in that lung that was completely infarcted. So what could go on the right side could be in a decent VQ match area. So that took care of the hypoxia quite nicely. We did not initiate VA ECMO at that point, and we decided that if she went worse, the intensivist and me decided that we would go for an embolectomy if she deteriorated, which she did. At 3 in the morning, the vasopressor support increased, and we called the team, and we were all there at 3:30. Lactates were 2, she was citing 91, but the norepi dose was what we could call massive. 2.5, here is what we use in our hospital. 0.5 is considered high dose. 2.5 is 5 times the high dose. And we waited maybe too long. The BP dropped to 50, almost non-pulsatile, and we had to start CPR and put the patient on VA ECMO. And then she was stable. So, so we did not use that setup. We put our venous cannula in the right femoral vein all the way to the liver and an arterial in the artery here. And this is the exact setup we had with a reperfusion line in the artery that was put in at the bedside. And since she just arrested, we decided to wait before we went for the embolectomy.
Yoan,
Yes.
a quick comment. This is where I think the heart team is important, because from my humble perspective as an interventionist, I mean, there's data from Goldhaber and the Brigham group that any PE with even submassive with RV dysfunction should be treated aggressively, not just with lysis. I mean, I think this is what Chris alluded to before. The steps slowly, gradually going towards a more aggressive, instead of, boom, you have someone RV dysfunction documented, why not? And this is where sometimes we call the surgeons and we're wondering, should we go? This reminds me of a patient I got last year with one of the colleagues, Ismail. So this is where maybe the surgery team should inform us of their level of comfort. And I understand it's within 4 or 6 hours of lysis. However, we went from a stable patient to a patient that was, CPR'd later on. So
It's obviously the whole team that was there at 3 at that morning, we didn't feel that it was optimal that we ended up in that situation. Having a very large clot proximally, and we felt that we missed our opportunity to go and get that big clot out. So we supported her with the ECMO circuit for a little while. We can turn back the slides.
Any comments from the audience? I mean, these are difficult cases. But
So it takes lots of courage to present a case like that. This is one of the aspects I find frustrating at times with pulmonary embolism, is that the surgical decision, the go or no go. So So it depends widely on surgeon, I must say. I will say. And what criteria can we use to
Convinced.
convince, or is it based on the, besides the shock status, is it based on the anatomy that you see on scan? Because it.
Very. We had, in the last 2 weeks, we had 2 massive PEs, and both had very good outcomes. I'm selling it already. Both, we did a lot of efforts to early on define if they were candidates that would be amenable to surgery. If there is a large clot in the main PA or in one of the right or left PA, we can go in and take it out. If there's no clot there, it's just a waste of time and of energy and risk for the patient to go in and have a sternotomy, cardiopulmonary bypass, and then open and find nothing and just reclose and hope that the patient will come off pump. So in that case, we had a clear plan to go for an embolectomy. And I think where we were, if she did not receive lytics, we would have gone earlier. The other thing is having the lactates going down, the systemic perfusion going better with a good urine output and the gases getting better. We thought that we would just turn around, which was obviously a false well, we thought it might work and it didn't. So anyway, we were there when she arrested. She was put on ECMO in less than 10 minutes because the whole team was there, but it was close. But then on ECMO, her SAT dropped to 68 on the SAT probe, and that was quite problematic. So that was what I was explaining earlier, that Harlequin syndrome, in which we have a drainage cannula here in the liver, the pump. We're sending oxygenated blood here at 3.5 liters per minute in the right femoral, which is going all the way up in the thoracic aorta somewhere. But it's partial cardiac output. There is some blue blood that's going in the RV that's pumped in the lungs that are infarcted, that's coming back to the left atrium and getting pumped into the aorta. And that's mixing somewhere in the descending sometimes, and then the head is receiving desaturated blood, or sometimes it's in the ascending, it's just the coronaries that's receiving desaturated blood, but it's a problem. So we did a few things to get rid of that. We increased the ECMO flow. We recruited the patient and put the FiO2 back to 100. We put some NIRS, which is cerebral saturometry, on all limbs to see what was the perfusion of all limbs and if it was correctly symmetrical. And we put the peripheral SAT probe on the right hand, and almost right away the Harlequin syndrome was corrected. So we did not have to put another cannula in to go in more aggressively. Yes?
It is a very good point. I didn't know about it. So you will put saturation in the ear lab, in the upper arm.
Right hand.
So you put it at several places, and then I guess there's always a little bit of a north-south syndrome. How do you define, is there a gradient in saturation in where you say more than 10% of saturation is problematic?
You usually don't have it because you empty enough of the ventricle and there's so little blood that's going through, and you just adjust your ventilator to make sure that the blood coming out is fine. But once you identify it, the risk is that you're just changing the area where it's mixing, and you can miss a coronary hypoperfusion despite having everything else perfectly satting. And you have to suspect that if that patient were to develop poor LV function, you would have to think, whoa, that's probably a north-south that's just on the coronaries.
Interesting, okay.
So 24 hours later, Sunday morning, she was almost weaned from her vasopressor. She still needed partial ECMO support for stability, no organ failures, awake, moving 4 limbs, and T confirmed that there was still some clot present. So that was her X-ray at that time. What would be your plan at that point? She's not weanable from ECMO, but she's all awake, no organ failure. Keep ECMO and heparin for a longer period as the only management. So who would go for thrombolytics again on ECMO? None. Who would go for keep on ECMO and heparin? Good. Who would go for percutaneous clot fragmentation? Maybe. Who would go for surgical embolectomy? Great. That's what we did. So we went in, we also planned to close the PFO, which we thought was dangerous at short or long term in that lady that had spontaneous PE. So we just added a cannula in the right jugular, deconnected the cannula from the ECMO, connected that to the cardiopulmonary bypass machine, went on to full bypass, opened the PA, we didn't arrest the heart, we just took forceps for, how do you call that? The pince à Dijon? Anyway, a forceps for the cleaning of the
Pulmonary
prep,
artery.
the surgical prep. Anyway, that's the kind of forceps we use, and we took a number of clots. This is 2 to 3 centimeter clots here that were removed from the main and right PA. And when she came back, that was her X-ray. And after 5 days, we were able to wean the ECMO to extubate her 3 days later with a decent biventricular function on repeat TE. And we sent her for follow-up with heart failure for the RV and respirology that was involved early on. So that was the case. Any comments? We discussed it quite a bit during the process, but any comments on the...
I think it brings up two important points, one of which is a lot of intensivists will say if you survive the initial PE and resuscitation and you're alive, then you'll probably survive the rest of the course. Unfortunately, she deteriorated several number of hours later, which is unexpected, so I can understand why there was a sudden change in plan. Although the other point is, if you're going to be aggressive, be as aggressive as you can up front. Because I think that, we could have lost her at the time of her arrest at 3 in the morning. Upfront embolectomy, already there were criteria for respiratory reasons, VQ mismatch and ongoing shock that was indeed improving, but still an unstable patient. It's a judgment call, and I think that's the point of the heart team, is that not one person would be comfortable making that decision. Obviously here, 5 people weren't comfortable making that decision to go with upfront embolectomy or ECMO, but I think it's a learning case, and I think we have to move on. But there's a lot of high-risk features here with the lactates at 9 and the RV dysfunction and VQ mismatching that clearly shows a high clot burden on the CT scan. Very low threshold for high-level support up front, exactly not to have a deteriorating patient.
Yeah. Stéphane?
I think it's a beautiful example of embolectomy, what should be embolectomy. Anything, the current status of what we have percutaneously is not doing embolectomy. And I call angiojet a clot sprayer, basically. It's just like pushing the clot everywhere. Basically, you're reopening some of the perfusion, but you're probably just dumping all that crap down into the lungs. So I don't think it's a good idea. Most of the data has been on much less sick patient than these ones. Maybe some patient could have even survived with medical therapy, and the series that angiojet or any pigtail embolectomy have been shown. So we're not very enthusiastic about that technology. I think however, if that could be done from a percutaneous approach in one future, that surely would be a good option, but I think we would need a much larger bore catheter and something that would be more effective, like Proxys used to be in saphenous vein graft, something that would wedge into your pulmonary artery and then suck it out with some pressure. But I think we have to be humble as interventional cardiologists and realize that there's nothing we can do that could yield as much embolectomy as you did.
Thanks for the comment. The clot we removed last week on a similar patient post-arrest was 45 centimeters long by 2 centimeters thick. With no lysis, the clots come together, so you just pull and the whole thing comes out, and it was this long. It's quite impressive. So sometimes in large clot burden, and it depends from center to center, but in that case, we were lucky in that lady that we did not lose her, because we did lose her at some point, and that's probably certainly a learning point for our team.
So since we're in the anecdotes, I'm always concerned, and it may be a personal pet peeve here, that we're going to push some clots in the inferior vena cava with the cannula. And I will always remember this case that we did last year where we, it was funny because our urgency doctor was her first shift at the Montreal Heart, and here comes this pulmonary embolism that keeps coding, and she's out of her algorithm, and she said, "What do I do next?" I said, "Well, let's do an ECMO." And then we brought the patient for the ECMO, and then when we did push the cannula, the patient coded, and it was done.
That's certainly a risk. I don't think that any group published results of 100% survival in massive PEs. Most massive PEs, though, happen not small bits at a time. It's when the big one goes. And if we were putting ECMO on everyone with a PE, we might have that problem quite often. But I think most cases that end up with an indication for support, it's because everything that had to leave left all at once, and the RV decompensated and led to shock or arrest.
If you go straight to surgery, will you put the venous cannula in the right atrium right from the get-go, or what are you going to do in terms of cannulation? Is it going to change at all?
We're going to establish arterial access, and then we're going to put 2 cannulae. If we have some time, we're going to put one in the SVC first, connect it to the circuit, and divert some of the blood, maybe cannulate the IVC later once we had time to do the TE and confirm there's nothing in there. But if the patient's crashing, we're just going to go and put one in, put the other one, so that we're on support as early as we can. Usually the right system is so congestive and huge that we just put one in, and the pump almost starts on its own.
I think that's where that's an experienced radiologist as well can sort of help you with cases like that. And in Calgary, the radiologist would often do sort of delayed venous images and be able to give you sort of a whole idea of clot burden in pelvic veins, IVC, so that if indeed you had to go for ECMO, your venous cannula will be preferentially SVC as opposed to IVC. So I think, again, the radiologist who knows what the story's all about and potential surgical or percutaneous options can help you with the decision of where to stick the cannula.
In that patient, that's exactly why we did the ultrasound from the start. Make sure there was nothing in the veins so that if things turned sour, we would have an access on the side. At least one side was not filled up with clots.
Very good. I think with last comments, I would like to thank the 2 speakers for the case presentation. I would like to thank you for staying up on time. I think the conclusion of this session is, I think, for the next of the 2 days, is the importance of the heart team to improve the outcome of our patient. And there's some gaps. I mean, the cardiac shock patient, I mean, the pulmonary embolism, I mean, matter of to evaluate with the team. I would like to have the slides so I can show you why you need to be here tomorrow morning early for a great session about the program of the Heart Team Summit. So next slide, please. These are our sponsors. So again, thank you. And again, this is 8 o'clock tomorrow will be the aortic valve patient, so heart team discussion. In the afternoon will be the mitral valve patient. So again, stay tuned tomorrow. We have great discussions, so be ready. Enjoy Montreal tonight. And again, thank you for your participation. Thank you.